This will be the 17th presentation in the PRCP webinar series for healthcare workers. Today's webinar is titled Different Types of Dementia. I would like an opportunity to introduce our two presenters for today. Therese Lawler has a background in social work and long-term care administration with over 30 years experience working in geriatrics in both clinical and management positions. Her experience includes working with long-term care, developmental disabilities, adult day programs, acute care, primary care, complex continuing care, community care, and psychogeriatrics. Currently, she works as a psychogeriatric resource consultant with the Toronto Regional Geriatric Program and the Scarborough Health Network in the Central East. Tony Shembry is a PRC with the Regional Geriatric Program of Toronto and the Scarborough Health Network in the Central East. Tony combines 25 years of experience in mental illness and acquired brain injury and holds 2 graduate degrees in education and in psychology. And with that, we will get started. Again, please feel free to type any questions or comments you have in the chat box at any time, and we will have time to address all of your questions toward the end of the webinar.
Thank you, Sasha. Thank you, Sasha. So we're going to actually just stay off camera just so that you can see the slides at the moment, but at the end of the presentation, we'll be back to answer questions. So in your chat box, what I'd like you to actually do is actually tell me, or tell us actually, how many different types of dementia do you think there are? So if you were to put a number on the types of dementia in the chat box, could you tell us how many do you think that there are? I'm going to take a minute to look at that. Okay, so we've got 5, 10, yeah. Okay. Would you be surprised to hear? Yes, there are over 400. So Gia, you're absolutely right. There are over 400 different types of dementia. So according to the World Health Organization, there are many different forms of dementia. Alzheimer's disease is the most common form and may contribute to about 60 to 70% of the cases. Other major forms include vascular dementia, dementia with Lewy bodies, and a group of diseases that contribute to the frontal temporal dementia, which is a degeneration of the frontal lobe of the brain. Dementia may also develop after a stroke or in the context of certain infections, such as HIV, harmful use of alcohol, repetitive physical injuries to the brain known as chronic traumatic apathy, or nutritional deficiencies. The boundaries between different forms of dementia are indistinct, and mixed forms often coexist. Worldwide, about 55 million people have dementia, with over 60% living in low and middle income countries. As the proportion of older people in the population is increasing in nearly every country, this number is expected to rise to 78 million in 2030 and 139 million in 2050. Today, we're presenting a brief overview of the types of dementia. There's not enough time in this webinar to go into great detail on each. And obviously, because there's 400 of them, we would need much more time. So at the end of the webinar slide deck, there is a reference slide with specific website links explaining the dementias in greater detail, as well as the other available resources that are there. Okay. Next slide, please. So, sorry, can we go back one slide? Okay. Oh, I'm missing one here. Okay, so what is dementia if we were to look at that? So according to, again, to the World Health Organization, dementia is a syndrome, usually of a chronic or progressive nature that leads to deterioration in cognitive function. It's the ability to process thought beyond what might be expected from the usual consequences of biological aging. It affects memory, thinking, orientation, comprehension, calculation, learning capacity, language, and judgment. Consciousness is not affected. The impairment in cognitive function is commonly accompanied and occasionally preceded by changes in mood, emotion, control, behavior, and motivation. And if we looked at what the Center for Disease Control and Prevention says, dementia is not a specific disease, but is rather a general term for the impaired ability to remember. To think or make decisions that interferes with doing everyday activities. Alzheimer's disease is the most common type of dementia. Though dementia mostly affects older adults, it is not a part of normal aging. Many older adults living their entire lives without developing dementia. Normal aging may include weakening muscles and bones, stiffening of arteries and vessels, and some age-related memory changes that may show as they age. Occasionally misplacing car keys, struggling to find a word but remembering it later, forgetting the name of an acquaintance, or forgetting the most recent events. Normally, knowledge and experiences build over years, old memories, and language would stay intact. Because dementia is a general term, its symptoms can vary widely from person to person. People with dementia have problems with memory, attention, communication, reasoning, judgment, and problem solving. Visual perception beyond typical age-related changes in vision. Next slide, please. So individuals with dementia suffer from cognitive impairment. So individuals, again, as they suffer from cognitive impairment, a loss of the previous mental abilities, can include problems with orientation, concentration, memory, language, calculation, and insight or judgment. Problems lead to confusion. Functional impairment is a change in the social or occupational functioning, reduced ability to perform activities of daily living, such as dressing, grooming, feeding, or toileting. So problems with thinking problems and doing things. Next slide, please. So what is dementia? It's really important to know that it's not a disease, but a set of symptoms that accompanies a disease. Next slide, please. So if we look at the progressive dementias, and these would be considered to be Alzheimer's disease, vascular dementia, Lewy body, frontal temporal lobe, or mixed dementias. So I'm going to talk a bit about these. Next slide, please. Okay, Alzheimer's disease. So this is what we consider to be the most common type of dementia, and it accounts probably for about 50 to 60% of the dementias. It's caused by a speed up of normal aging processes in the brain. It does not have a single cause, but there are a number of factors that have been found to increase a person's likelihood of developing it, including cardiovascular disease and family history. It is a degenerative condition. The symptoms become more severe over time and usually begins in the mid to late life. They've survived for up to 10 to 15 years after a diagnosis with Alzheimer's. If we look at the global deterioration scale given by Reisberg in 1982, it starts with forgetful and absent-minded, forgetting appointments, misplacing items, fatigue, difficulty recalling familiar words, difficulty with speech, finding the right words, inability to learn new things, deterioration in judgment and behavior, diminishing orientation to time and place, loss of logic and memory memory problems become more severe, ability to read, write, and calculate become more difficult, disoriented, loss of insight, diminishing ability to carry out daily activities such as washing, dressing, preparing meals, and using the telephone, impatience, restlessness, and wandering disorientation, physical and verbal responsive behaviors to frustration, speech, verbal skill, and ability to calculate declines, social skills decline, paranoia, bladder and bowel control decline. Many become completely dependent for daily care, ability to speak or follow simple commands decline, and behavior changes may become responsive or adopt a totally passive attitude, shuffling walk and slow and awkward movements. So that's kind of the progression that we're looking at as Alzheimer's begins to progress. Okay, next slide, please. Vascular dementia, this is what we consider the second most common type of dementia in older people. Vascular dementia is caused by a lack of oxygen reaching cells in the brain and causing cells to be damaged. This leads to reduced brain activity. The most common symptom of vascular dementia is a significant slowness of thought, and it is a degenerative condition. It gets worse as time goes on. A general loss of intellectual abilities caused by problems in the circulation of blood to the brain. Mini strokes that can cause enough brain damage to result in dementia, and the symptoms that result can be quite varied. Progresses gradually, sometimes in a stepwise fashion, meaning that the person's abilities will deteriorate after a stroke and then stabilize until after the next stroke. More males than females are affected. Next slide, please. Lewy body dementia. It's caused by a buildup of proteins called Lewy bodies in the body. Lewy bodies are also what cause Parkinson's disease, which is why both illnesses share the symptoms of reduced mobility and a shuffling walk. Lewy body dementia also causes significant mental decline associated with other major types of dementia, including lapses in memory and forgetfulness. It can be very difficult to diagnose, so likely it's more common than we once believed it to be. Distinct cognitive impairment with fluctuating confusion, visual hallucinations, delusions, falls, and Parkinsonian motor difficulties. Very sensitive to the antipsychotic medications. And it may be more rapid in progression than Alzheimer's disease, which is the same as a frontal temporal dementia, which is the same. Okay. Next slide, please. So if we looked at mixed dementias, so according to the Center of Disease and Prevention, mixed dementia, sometimes more than one type of dementia is present in the brain at the same time, especially in people aged 80 and older. For example, a person may have Alzheimer's disease and vascular dementia. It is not always obvious that a person has mixed dementia, since the symptoms of the one type of dementia may be the most prominent or may overlap with symptoms of another dementia. Disease progression may be faster than with one kind of dementia. In the most common form of mixed dementia, the abnormal protein deposits associated with Alzheimer's disease coexist with blood vessel problems linked to vascular dementia. Alzheimer's brain changes also often can coexist with Lewy bodies, and in some cases, a person may have brain changes linked to all three conditions: Alzheimer's disease, vascular disease, dementia, and Lewy body dementia. Mixed dementia symptoms may vary depending on the types of brain changes involved and the brain regions affected. In many cases, symptoms may be similar to or even indistinguishable from those of Alzheimer's or another type of dementia. In other cases, a person's symptoms may suggest that more than one type of dementia is present. Researchers expect to gain a greater understanding of the mixed dementia symptoms as long-term studies continue to shed light on the relationship between cognitive function and the underlying brain abnormalities. And with the next slide, I'll pass this over to Tony.
Thank you, Therese. That's actually great. We're going to be looking at frontal temporal. Frontal temporal dementia is less common than Alzheimer's and vascular dementia. It is the most common type of dementia for people under 65. The damage to the brain cells affects the frontal and temporal lobes of the brain. These are the areas of the brain related to problem solving, behavior, and recognition. The term frontal temporal lobe dementia covers a range of conditions with damage in the frontal and/or temporal regions. These areas are responsible for our behavior, emotional responses, and language skills. The frontal temporal lobe is about 40% of your brain. It is a rare form of dementia. Younger individuals or people, particularly those under 65, are more likely to be affected. It occurs equally between men and women. About 50% have a family history. Symptoms will vary depending on the region of the brain affected. Each person will experience a disease in their own way. Often, in the early stages, memory remains more intact. Important to always remember these symptoms are due to brain damage and are beyond the person's control. Behavior changes may be more evident in the early stages, not always evident on formal cognitive testing. Changes in personality preceding memory impairment. 50% affected have a family history of this dementia. Next slide, please. Young onset, also known as early onset. Accordingly, the Alzheimer's Society, Alzheimer's disease is considered to be young onset Alzheimer's if it affects a person under 65. Younger onset can also be referred to as early onset Alzheimer's. People with younger onset Alzheimer's can be in the early, middle, or late stage of the disease. The majority of people with young onset have sporadic Alzheimer's disease, which is the most common form of Alzheimer's and is not attributed to genetics. Doctors do not understand why most of the young onset Alzheimer's appear at such a young age. However, researchers know genetics play a role in Alzheimer's. There are risks, genes, which increases the likelihood of developing a disease, but not to guarantee it will happen. And there are deterministic genes that directly cause a disease, guaranteeing that anyone who inherits them will develop the disorder. Next slide, please. Mild cognitive impairment. Alzheimer's Society of Canada suggests people living with mild cognitive impairment, commonly referred to as MCI, have problems with memory, language, thinking, or judgment that are greater than the cognitive changes associated with normal aging. As its name implies, the problems experienced are considered mild, not as severe as the symptoms experienced by persons living with dementia. The cognitive changes associated with MCI are usually not serious enough to interfere with a person's daily life and independence. However, friends and the person living with MCI may notice these changes, and they can be measured in tests. A person with MCI can experience a wide range of cognitive symptoms, such as memory problems. For the majority of people with MCI, memory is the ability most affected. Impaired thinking skills, language difficulties, disorientation in time and space, poor judgment, and impaired perception. Next slide, please. Conditions related to dementia, which we included Down syndrome. And again, the Alzheimer's Society suggests that people with Down syndrome have an extra copy of the 21st chromosome, which can cause learning difficulties, health issues, and other symptoms. However, thanks to recent medical advances, people with Down syndrome are living longer than usual and well into their 50s. Down syndrome is the most common genetic cause of severe learning disabilities in children and cause developmental delays, learning difficulties, health issues, and some physical abnormalities. The first sign of dementia in individuals with Down syndrome is often changes in their behavior and personality. In an individual with Down syndrome, it is essential to pay attention to these behavioral changes, especially reduced empathy, social withdrawal, emotional instability, and apathy. Another warning sign can be if the individual with Down syndrome is experiencing seizures for the very first time in their life. Ideally, at age 30, every individual with Down syndrome should have testing done to assess their cognitive or functional abilities. This baseline can be used when assessing if the individual has experienced a decline in cognitive ability or functioning. It can be helpful to conduct regular testing to monitor cardiovascular health, diabetes, and to differentiate between other conditions that may present similar symptoms as dementia. Next slide, please. Conditions related to dementia, traumatic brain injury. Alzheimer's Society in Canada suggests a traumatic brain injury, commonly referred to as a TBI, may occur when a person experiences a sudden injury to the head caused by an external object. However, not all head traumas will result in a TBI. A TBI can happen if an object forcibly hits a person's head or when something pierces through the skull into the brain. Either of these experiences can cause damage to brain cells and blood vessels, and a person's physical and cognitive functioning can be broadly affected as a result. The extent of a TBI depends on what part of the person's brain has been damaged and the severity of the trauma. A TBI is also commonly referred to as acquired brain injury or a repeated head trauma. Dementia pugilistica and punch drunk syndrome are two of the terms used to describe a TBI that is caused by the repeated brain damage that can result from contact-heavy sports, such as boxing or football. A TBI is often characterized as being a mild, moderate, or a severe brain injury. Next slide, please. Rare types of dementia. On this slide, you will see a list of the types of dementia. There is not enough time in this webinar to go into detail, as we talked about before. To learn more about these rare dimensions, the resource slide at the end of this slide deck will provide your specific organization that explain each condition in detail and where further information can be located. For those individuals who have been diagnosed with these rare types of dementia, it is critical that healthcare providers gain more information and understanding about the condition so that they can develop an individual specific plan of care unique to that individual's needs. Next slide, please. Dementia-like conditions. So things such as infections and immune disorders, metabolic problems and endocrine abnormalities, nutritional deficiencies, medication side effects, subdural hematomas, brain tumors, and normal pressure hydrocephalus. Next slide, please. Reversible causes. Reversible causes, people who have dementia may have a reversible underlying cause, such as a side effect of medication, increased pressure in the brain, a vitamin deficiency, and thyroid hormone imbalance. Medical providers should screen for reversible causes in patients who are concerning for dementia. So again, medications, drug interactions, side effects, nutritional deficiencies, especially things like B12, metabolic syndromes, tumors, depression, delirium, and normal pressure hydrocephalus are some of these reversible causes. And I'll pass this on to Therese.
Thanks, Tony.
Quite welcome.
Okay, so what we'd like to kind of take a look at is the core thing that of all of this, because there are 400 different types of dementias. One of the questions we often have, or you probably have already come across many times, is somebody will say to you in a very generic fashion, that person has a dementia. But the key thing that we need to all realize is we need to know what the dementia is related to. So the question might be, why do we need to know that? Because in order to be able to better provide care for that individual, we need to know what the background is and what their other medical conditions may be. So when we look at the daily questions we could kind of more or less look at when we're looking with somebody with dementia is probably at least the ones that we have up here. So who is being impacted? So if you were to look at this, and maybe in the chat box, you could tell us, if you were looking at dementia, who do you think is being impacted? In the chat box, if you just type that in, and maybe Sasha can just let us know what comes out.
Absolutely. The caregivers.
Yeah.
Family. The patient and caregivers, families and friends, the person with dementia, the community, the person and their family and employer. Oh, we got healthcare providers, the individual, family members, friends, neighbors, the care team. Lots of great answers coming out.
Absolutely. Absolutely.
Yep.
You're absolutely right. So these are all of the individuals that are impacted by that diagnosis of dementia. So it comes back to the core question of knowing what disease is the dementia diagnosis linked to. We need to know that. Because once we know what it's linked to or what the diagnosis is linked to, we then can begin to kind of look to see what are some of the situations that we're seeing with that individual that they're having difficulty with. So for example, somebody with Parkinson's and Lewy body dementia, or somebody with Huntington's and a dementia, somebody with any of the other types of the disease processes, Down syndrome and dementia, they all present differently and they all have different needs and they're all unique. So it's really, really important to know what's the disease that's being associated with that dementia. So the next thing comes is where to access more information. So where do I get more information about the disease? So once we know what dementia is like, or once we know that they have a dementia diagnosis, we might then want to kind of say, for example, if the person had Huntington's, we would then maybe want to kind of take a look, which would be critical for the individual, as to the Huntington's Society. What information do we know about Huntington's? How do we know that it presents? How do Huntington's and dementia kind of in similar behaviors may have situations that we see? So the question might be, once that we might need to contact somebody from the Huntington Society to kind of get a better understanding of what are some of the behaviors, what are some of the situations that actually present with somebody who presents with Huntington's. And that will actually help us in kind of developing a formable care plan for them. When to apply assessment tools. So at what stage do we need to look at, hey, you know what, maybe we need to bring in external resources, maybe we need to do more assessments. So usually if the behavior is, if it's changed, if it's creating a problem with their activities of daily living, if it's difficulty in being able to function, these are things that we may need to look at assessments and actually figure out which assessment tools do we need to look at. And then why might a specific behavior be occurring? So why might we see a specific behavior occurring? Is it due to a specific type of dementia? Is it due to the disease process that individual has? So again, why might we be seeing the behavior that we do? And then of course, the next question is, how do we determine if the external resources are needed? So when do we make a decision as regards to when we need to bring in external resources? And I guess I'm going to actually throw that out in the chat box again too. Anybody maybe could give some idea of when do you think you need to pull in external resources? When are they needed? And maybe if you could just take a minute to put that in the chat box. When do you normally call in external resources? Yes, when safety becomes an issue, caregiver burnout, absolutely.
Absolutely, yep.
When behaviors escalate, more difficulty, absolutely, absolutely.
Yep, good answers.
Family no longer able to care for the client, yes.
Yeah,
When
sadly.
a patient is distressed,
Yep.
absolutely. Wonderful, wonderful answers. So the key point in all of this is actually we need to keep always asking ourselves the question, who, what, where, when, why, and how. So what are we looking at here? And what do we need to know more about? Okay, next slide, please. So dementia, again, is a diagnosis. And so again, it's connected with a set of symptoms. And we know it's not the disease, it's part of a symptom and the diagnosis. So we need to look deeper for the understanding of what we're actually seeing. So this is the key thing, is looking deeper, looking further, and getting more information to kind of figure out where we need to kind of go with that. And if we go to the next slide, please. So as you can see here with the references, and there's loads of references both on this slide and the following slide as well too. all of these are fantastic resources that give you more information, that give you a little bit, that can guide you as to what direction you may need to go. So even if you were looking at to knowing a little bit more information about a particular dementia, you might want to know, where else do I need to go? So for example, you have the Huntington Society, Parkinson's Society, they're all connected there. RENA, you know, the MS Society, there is a slew of resources. When you receive the slide deck, all you need to do is click on it, and you'll actually discover where more of the where it can lead you to, and what you need to kind of get more from. Okay, so on that note, I think we're going to open it up for some questions, and we'll come on video here for you.
Yes, thank you so much to Therese and Tony for sharing your expertise on the different illnesses causing dementia. I really find this such an interesting topic, and you both shared some great information that can shed some light on the varying manifestations we may see from those who experience the different types of dementia. So we do definitely have some time for questions. Again, I'll just remind our participants to please feel free to type questions into the chat box, and ensure that you change the to selection from all panelists to all panelists and attendees, so that everyone can see the questions. So I did have a couple of questions that came up throughout the presentation. If I can just, here we go. So we have a question, is it possible that Alzheimer's is the most common because it is more known, or maybe overdiagnosed? And could it actually be a different type of dementia?
Yeah, absolutely. I think what you're probably looking at is this as research is continuing on. The predominant one definitely in long-term care right now is Alzheimer's. There is absolutely no doubt about it that as time continues on, your age set changes, your demographic change within the long-term care home, it can certainly change, and it may no longer be the one that's at the top one, because vascular dementia is actually coming up very quickly behind that. So again, absolutely, somebody can get a diagnosis of Alzheimer's just because sometimes you'll hear that, oh, they have a dementia, I think it's Alzheimer's. And that's as far as that goes. Again, your question there would be, how do you know it's Alzheimer's, right? Has the person been assessed for that? So again, this is something that you would need to kind of decipher a little bit further. I hope that answers that question, or kind of touches on that. I don't know whether Sasha and Tony, you want to add anything to that?
Well, yeah, it's interesting, Therese, because I find that sometimes having the diagnoses might actually cause more troubles. And so really, it's about caring for that individual and looking at what kind of things, as you said earlier with all the questions, how can we help support that person specifically? And getting to the root of what are some of the issues really matters more.
Yeah, I also just wanted to mention too that I'm not sure if things have changed, but I know that like a definitive diagnosis of Alzheimer's disease can't take place until autopsy even. So
absolutely, yes.
Having that definitive diagnosis is often difficult in the climate that we live in right now, because there is no, like serum testing that can say, yes, this is definitively Alzheimer's.
Absolutely. Yeah.
That's perfect, Sasha. Thanks.
Yeah, I have a couple other questions here. We actually got lots of questions. Okay.
Some we may not be able to answer. Some
exactly.
But we can direct you to where you need to go for the answer.
So I have one here. It says, when and what setting should and does this type of in-depth assessment and exploration take place, as help is not usually looked for until crisis mode, causing hospitalization or caregiver burnout?
Yeah, that's difficult, because really sometimes you get the information when you probably needed it several weeks before, and it's just then getting that information. Really, it's a time game.
So one of the key things, I think, a lot of this probably has to do with educating family as well too, and care providers in the home setting. Because when you're looking at somebody who has dementia who lives at home, sometimes when you really kind of look at it, like, forgetting your car keys, et cetera, we don't really kind of attribute any of that. And that can be normal, because ourselves, we can forget our car keys and where we put it. But when they start to forget how to come back home, when they forget where they actually live, when they go out to go to the grocery store and they don't know which direction to go. These are all indications that, there's more issues going on here. And usually in those kind of processes, there's usually a situation where what'll end up happening is the family will finally decide that they need to kind of take a look at, there may be more issues going here. So they would probably then look at, depending if it's an elderly person, a geriatric assessment. So that would be one of your clinical settings, such as your gain settings, such as your other clinical settings that are in different locations. And I just say gain because that's our in the Central East, right? But there are more for sure. So you might actually look at, it may be much deeper than that. You may need to look at, a psychiatric assessment. You may need to look at the whole component. You're really looking at a holistic point of view. And then what's the best plan of care? Can that person live at home with memory reminders? Is there enough support structures within the home to able to manage that? Do they need to go to a specialized day program? Will that be something where they could remain at home for a longer span of time? Could they live in a retirement setting with enhanced supports in place? Could they live, or do they need to go to a long-term care home because they now need full assistance? But bottom line is it starts with noticing, and usually Alzheimer's diagnosis or dementia diagnosis, it's already started its process within 3 years before people really kind of realize, we have an issue or a problem here.
The other thing, Therese and Sasha, I noticed that there's a lot of stigma associated with people's behavior at different facilities like long-term care. Oh, my mother would never do that. Oh, my father would never do that. So we really have to be gentle when we're supporting, because as you noted in some of our discussion today, people have a constellation of family, friends, loved ones that really understand them at a different point in time. And so any of this could be really stigmatizing.
Mm-hmm. And I think a key point too is where you've got individuals who, remember too, it's usually the people that are in connection with that individual that notice the changes first. It's not the individual themselves, it's the actual person. And it could be, again, when you're hearing things from, say, for example, they normally would go to the grocery store and you're hearing that, mom came to the grocery store, but now she can't remember where the items are on the shelves or where to go or how to get back home. These are all, things where care providers may hear this. They need to kind of go, now we need to really look a little bit further.
Yeah.
Sasha, do you want to add anything there to that?
No, I think you guys, absolutely, you covered it. I think it's more about, the people surrounding, like they mentioned, the community around them that notices some of those signs and symptoms first. And it takes it really is, these are diseases that affect everybody within that community.
Yeah, absolutely. Absolutely.
Okay, I do have some more questions. This one is from Holly, and she asks, how does a diagnosis determine the difference between Parkinson's and Lewy body disease?
Mm.
That is a good question. I don't know if I know the answer to that, to be honest.
Nor I.
So this is what I'm going to suggest for you, Holly, because this is again too, is I would suggest that you contact the Parkinson's Society. That's an excellent question. A lot of actually the Parkinson's has a fantastic educational program that is actually really great for out in the community and also great in long-term care. And it actually goes through exactly the question that you're asking. So if you look on the slide deck right there, you'll see the Parkinson's Society, and I suggest that you link with them, because then you will get somebody who's actually expert in Parkinson's disease and Lewy body, and will give you direction as to where to go from there.
Yeah, lots of nuances that we may not be able to get focused on because it is complex.
Yeah.
Okay, and we do have another question about the last stages of dementia. Can a person become bedbound?
Yes.
Yes.
Yeah.
Yep.
I can talk from experience of working on the floors in long-term care, and in actual fact, in the very end stages, what ends up happening is things begin to shut down. So, and I'm sure Sasha, you can respond to this as well too, where you're looking at they forget to swallow. Those are the final kind of stages. So, you know, those are all, their system is actually really shutting down. So absolutely, the final stage is almost what you would classify, I suppose, as a palliative state, right? Very difficult.
Yeah.
Very,
And
very,
depending
very
on the
difficult.
area of the brain that's affected, it might be,
Yeah.
you know, affecting those motor, and that might even come earlier than some of the other symptoms that we're seeing, depending on what area of the brain is being affected by the disease that's causing the dementia.
Absolutely.
Yep.
Absolutely.
Okay, so we still got some time here, so I'm going to go through a bit more
Yeah,
questions.
sure. Go ahead.
Good.
Okay. So we have another one here. So can antidepressants help with flat affect associated with dementia and Alzheimer's?
That's a good question. I've seen it work in some cases, but then what ends up happening is over time, they have to find something else because it stops working for some reason. Has that been your experience, Therese, Sasha?
In terms of flat affect with dementia, from my experience, it's a little bit different than the affect in depression. But I can't speak honestly to whether an antidepressant would work in that area. That's not my area of expertise, but it is, again, a great question. You guys have a lot of really good questions up in here.
Yeah.
So, and I agree with Sasha and Tony, which you again, we need to look at, we've got the resources here as well too, but you would be looking at the assessment piece. So this is where you would have either probably the geriatrician in conjunction with the rest, if you're actually, would actually give you a better idea as to what's the best for that individual. But with, again, too, you can also, psychiatry works out really well too. So you've got, you know, again, GMOT, BSOT, you've got slews of different teams that are connected. And this is a question that really should be answered by them.
Exactly.
Yeah. Yeah.
So I do have a question about Down syndrome.
Yeah.
So in individuals with Down syndrome, do they cycle through the typical stages of dementia the same way as someone who does not have Down syndrome? So is it a similar progression?
Yeah, in some ways it is, but usually somebody with Down syndrome, they're usually a bit younger when it starts to cycle through it, and it can move very quickly. Again, I'm going to pull you back. These are great questions.
I know.
Up on the screen, you're going to see Surrey Place. You're going to see RENA, and those are two organizations that can answer those specifically. That are actually really good in being able to point out exactly what you know, you would see in Down syndrome and dementia. I would strongly recommend Surrey Place because they do education for staff. As well too. So remember, all of these that we're talking about will come into your homes, your community centers, your adult day programs, wherever you're located, and provide an education specifically on that. So this is what you want to do, is develop those linkages so that staff actually begin to have an understanding with regards to the different conditions that you see.
It's interesting because it seems like really what we're saying is you almost have to be a detective.
Yeah, absolutely. Yeah, absolutely.
Absolutely. And as you guys mentioned, there's 400 different kinds of dementia, you know, and to think about how mixed dementias exist, a lot of these can cross over. So you can have a lot of symptomology of one type of dementia and then express other symptomologies of other types. So it becomes really difficult to decipher exactly what you may be experiencing. But I think it's really great that you guys do offer so many of these resources. Because if you are interested in learning about a specific type, you can really go in and do that detective work like Tony mentioned, and really, you know, kind of feed some of that, some of those gaps in knowledge with that particular type.
Yeah, that's it, a gap in knowledge. Yep.
Yeah. And I have to admit that I'm going to be going to a lot of these too to kind of freshen myself up, because they do crisscross a lot, and it can become a little bit difficult to put your head straight on which is which and what kind of course that looks like. And I'm going to answer, because I literally have so many questions here. So I want to make sure that I am trying to get to a lot of you. But there was a question about the resources that can be provided by the Parkinson's Society, example, music or soft toys. And I know that the Alzheimer's Society does provide some of those things like iPods, etc. I'm not aware of the specifics that the Parkinson's Society does provide, but I'm not sure if you guys do know, or if, again, we can just direct to parkinson.ca.
So again, I think that this is what you need to kind of to take a look at. Yeah, they will provide you with certain things required. And again, if they don't provide it, they're going to tell you definitely who their link is and who will provide it for you. There is, and I'm sorry, I'm trying to remember off the top of my head, there is a specific training program that's being done for clinical staff as well as staff on the front line through the Parkinson's Society, and I think it's called Act First. I could be.
That
I'm
sounds
trying to remember
familiar.
whether it's Act First or whether, but again, it's very specific. They also will tell you exactly what's the best strategy in kind of dealing with some of the issues that you would have when you see individuals who are struggling with Parkinson's and Lewy bodies. So this is where we're going to direct you back. I know it sounds like we're directing you back, but we're doing it for a purpose. And the purpose is so that you can actually take a really good hard look at what your individual client or resident or member requires in that need. So remember, there is no, and I'm sure I can talk for all of us on this panel here. It doesn't matter how many years you've been in the field. It doesn't matter which continuum of care that you've actually worked in. Here's the reality: you are going to have clients and you are going to have individuals that present with different needs. So you're always going to have to keep yourself kind of in queue with regards to the resources that are out there and who can you tap into, and never be shy to ask what other resources work with you. So for example, the Parkinson's, who else works with you when you have this situation? You would be amazed with the wealth of information that each of these have. So please, at any point in time, I really, 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 really strongly recommend that you actually connect.
Me too.
I do also see that there is a hand up, and I know, sorry if I'm saying this incorrectly, but it's Jane or Gahane. I did see that you had a few more questions and comments. So I know that you were saying that one of the biggest struggles we have is that we know what can be done, but it's not synchronized within the healthcare system. And I know that can often be, you don't know where to go, or who to tap into. But I think it's just really looking to your, external partners as well, who can help you and guide you maybe in some of those decisions. Maybe, I don't know if Therese and Tony want to add to that.
Yeah, I'd actually gonna say this too, because I think this is a key thing to remember with everybody. All things snowball from one thing into the other. So when you begin to kind of take a look at one area, you'll then begin to look at others. Now, for example, the additional resources and the references that you'll see that we're providing you with today will actually give you that ability. It's already, the link is there. All you have to do is click on it. So it'll already give you that contact that you need in specific area there. But that will then lead to another contact, right? So that as you go along, as you continue on in this journey of working in the continuum of care with individuals, you will actually build your own understanding with regards to what resources are available. They always change, but they're always there as well too. So the trick is to kind of really figure out how do they kind of dovetail one into the other, and ask those questions. Who else do you work with in the organizations to provide the answers? Remember, always go to the source. Right? When you're looking for information about a specific dementia or a specific illness or a diagnosis, go to the source to find out where exactly is that coming from, and and how much more information can they provide us with.
Exactly.
Okay. I have another actually really great question here in terms of sorry, I was just going to read out. It was from Nicole. She mentioned that she didn't realize that lack of empathy was a symptom of dementia. Is this common to all types of dementia? And if not, which diagnosis are we most likely to see this lack of empathy?
So I guess we need just maybe a qualifier with that. Are we talking about lack of empathy with the client? Or are we talking about lack of empathy
as a symptom of dementia? Mm-hmm. So the person with the dementia may have experienced lack of empathy?
Yeah. Again, I would think, I mean, I don't know, maybe Tony can answer that. Would that not be something connected with a frontal temporal lobe?
It's really interesting because I was thinking about that as we were talking. Who is perceiving the lack of empathy? Is
Right.
it the caregiver? Is it the house staff? Is it, so it's not a touchy subject, but it's difficult to unravel. And so I think it's very appropriate to start looking at the references and see how we're defining it and who's defining it and how it could work for us. It's hard to say, isn't it?
Yeah,
Oh,
absolutely.
it also says they believe that you mentioned it as a sign with Down syndrome, and it was a change for someone with Down syndrome. Sorry, I'm being corrected in the chat here.
Okay.
Okay, so you're talking about Down syndrome. Let me just see where you want to.
There we
So
go.
a lack of empathy with Down syndrome. I'm not too sure whether, again,
Here's where we really need to keep good data, because I gotta tell you, how do we, before this happened, were they unempathetic before? And is this a change in their behavior? And so you have to really understand that, because yeah, maybe they had autism, and maybe, in terms of people with autism, they may look like that. And this is not a change in behavior, but then eventually it can be.
okay, I think what you're talking about here is apathy, actually, not empathy. I think what you're probably referring to there, I'm not too sure who that was, but I think you're talking about apathy. Apathy in the context of dementia, when we're looking at it, is completely different than what apathy and depression is. So
Yes.
apathy in dementia is actually losing. What it is the person really wants to be involved in something and really wants to be part of the functioning of something, but you have to initiate the brain. You have to kickstart the brain to get them to participate in something. So, for example, somebody may really want to go down to the the bingo down in the recreation, and you ask them, would you like to go to bingo? And they'd say, yeah, and they don't move. They seem apathetic, right? They just don't move because they don't have, and you think that they're not motivated, but in actual fact, what they need is you to start moving them to come down to the activity. And
Exactly.
I think so. When we were talking about Down syndrome, it wasn't empathy, it was apathy we were talking about.
Good point.
Okay, so yeah, maybe it was just a mishearing there.
Yeah. I do want to, there was something I saw there though, and I just wanted to come back.
Yes,
Somebody
please.
had asked is, how does the no, where are we at? Where are we here? Does the diagnosis, and I think Ruth asked this question, it's a really good one. Does the diagnosis assist with the treatment options? Absolutely. So this is where the key thing is you got to make sure that's the right diagnosis attached to the the resident or the client, right? Because if you don't have the right diagnosis for that individual, you may not have the best treatment plan for them, right? But absolutely. Okay, is there a couple more questions coming in, I think?
Yeah, you know what? I'll maybe give you two more.
Okay.
This one is actually really great too. So it was talking about tough sports when you mentioned football and any of those more hands-on sports that can trigger a TBI. How is that related to concussion? So I guess that's a big thing that's been coming up in recent news and sports news.
Yeah, it's true.
Yeah. So
Don't you want to answer that one?
I will. So I got to tell you that some of these sports, what is that? Is it what is it? Where people are fighting with their feet and with their hands, and they're really having a brawl. It looks like a brawl. You can get really hurt in that arena. So
The
anything,
kickboxing, yeah.
That's it. Yeah. And if you have any or a number of insults to the head, that can cause all kinds of damage. Hockey, for example, but they have helmets, and that still produces a lot of damage. So it really depends on how many times your exposure to it, how long have you been playing. A lot of boxers in general, even though they have padded gloves, they get a few hits to the head, and that's a problem. I hope that answered the question.
Yeah,
I
no,
mean, I
that's
think,
a great answer. Oh, sorry, Therese, go
yeah.
ahead, please.
No, I was just gonna say, like, I mean, even the concussions that they suffer from hockey or basketball or whatever, more times that they hit their heads, right?
Yeah.
Absolutely. And I would love to end it off with a couple questions that have come through, and they're all around the same thing. And that is, if there's any new research for dementia, new dementia treatments that you know about, or I know that there's always ongoing research, but where is maybe the best place to find some of that most recent data in terms of treatments and research for different types of dementia?
So go to the reference slide. You are going to see tons
I
of
knew you were going to
things.
say that. I knew you were going to say that.
Absolutely tons of things. And you know, Samir, he's doing, you see the NIH, that is fantastic research that's
Yes.
been done. And they're in connection with Ryerson. So that is fantastic in that sense. So absolutely. And I think some people have, oh, there you go. And I think there's been a few that have written in, the AFTD organization is doing an education day on April 2nd.
Woohoo.
There you
Excellent.
go. And so there's absolutely, and you will find on these references as well too, links to other areas that will definitely tell you where you can find more information and the research that's actually done there, for sure.
You know, I think what you said earlier, how things can go a snowball. I think we have enough information here to make an avalanche.
Absolutely. And that's a good thing. We can never have too much information, right, guys?
Truly.
Well, I want to just, say thank you so much, Tony and Therese. This has been a really great conversation. Thank you for the participants for getting so involved. You really stumped us on a few of those there, but I think that there's enough resources within those slides that can really get you a lot of the information you were looking for. And I really want to thank everybody for attending this webinar. You will receive a short evaluation and the YouTube link by email. And please share your suggestions and topics for future webinars. And please let us know, did you find this helpful? What other topics would you be interested in hearing and learning about within these webinars? We always look for any suggestions. So thank you so much.
Thank you.
Thank you
so much. It's been great, everybody, as well too. Thank you for joining us.
I love the questions. They were great.
Yeah, they're fantastic.
Fantastic.
Fantastic. Absolutely fantastic. That's great.